Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise, and we meet every Saturday at 9 a.m. Central Time. If you're watching this on YouTube, LinkedIn, or Facebook Live, welcome to the show. For you YouTubers out there, hit that subscribe button for me. And if you're new to the show, be sure to check us out on uronurse.com, where you can learn more about the show. It's also the best place to go for our past episodes. I put 49 episodes. We actually have 50 episodes. So catch all those old episodes on the uronurse.com website. Also, if you want to contact us, you can use the website to send us a letter, an email about whether you got an idea for a show or somebody you think would be a good speaker, or maybe you got a favorite story from your own practice that you want to share. You can hit that share stories button. And if you're watching us live, this is your way to contact us. Now, I see some of you have already started to put in your locations. I really appreciate that. We get to find out where everybody's coming from. We got a great show for you today. We're going to have Dr. Arpeet Shah speaking on Aquablation. This was one of the requested things that came in through the email program. So we're going to go and get to our great panelist right now and have everybody introduce themselves. So welcome, everyone.
Hello, hello.
Hello.
Hey.
So for those of you that I announced myself, Vic Sinise, I've been involved in urology for the past 40 years, and UroNurse was my way of giving back to the profession. So we're going to always like to lead off with an introduction and a favorite story. I'm going to actually lead off with something a little different. Instead of a favorite story, I've got a show. Commercial for next week's show, and I'm going to bring that up right now.
The internet is buzzing with excitement as we prepare for the one-year anniversary celebration of UroNurse.com, a revolutionary healthcare education platform. In a world where healthcare meets innovation, UroNurse.com has thrived and transformed lives. 1 year ago, we embarked on a journey to redefine urological care and empower healthcare workers. We've connected healthcare workers with compassionate urology experts and life-changing resources. And we've never stopped innovating. Our user-friendly interface has made urological information accessible to all. My dedicated team has been the backbone of this success. To many more years of excellence and transforming lives. Celebrate with us July 29th at 9 a.m. Central Daylight Saving Time on uronurse.com.
So that was my favorite story. Join us next week for our 1-year anniversary. All right, Lori, I'm going to bring you in here. Go ahead and introduce yourself and let us know your favorite story.
Good morning, everyone. My name is Lori Atkinson. I am a certified urology registered nurse, and I've been a urology nurse for 25 years. I currently work for Northwestern at Delaware Hospital, also at Central DuPage Hospital in Winfield, Illinois. Excited to be here. I do have a little story. I don't have a whole lot of information, but it seems like I always have a story every week. This is something that I've never seen before in the 25 years that I've been in urology. We had a patient who presented to the ER with a lump in his groin, a rather large lump. And he ended up having metastatic squamous cell carcinoma of the scrotum. And the reason why he had never really noticed it on the scrotum is because he was on the obese side and he couldn't see it. And so I think it's really kind of stumping our urologists as well as the oncologists on really how to treat this. It's pretty difficult, pretty rare. So.
Yeah, wow. That is unusual. Great story. Hey, John, welcome from Arizona.
Hello, everyone. My name is John Lin. I'm a private practice urologist in Gilbert, Arizona, who, like Vic, is paying it forward by sharing my experience in the business of medicine to benefit my colleagues. One of the ways that I'm doing so is by creating the Thriving Urology Practice Facebook group, where now over 2,300 US-based urology practice folks collaborate to improve our practices, and it's all for free. And when it's free, I say that it's for me. One story that I do have is that I would like to say that, I just came back from Maui yesterday, and I stayed at the Ritz-Carlton. It was for a continuing medical education course. I stayed at the Ritz-Carlton Kapalua on Maui. Beautiful resort. We signed up for something called the club, which allows you to eat 5 different courses of 5 different meals, if you will. Like they have hors d'oeuvres and things like that. Beautiful setting. You could sit indoors or outdoors. Now, the weather was beautiful. It was in the 70s, slightly humid, but it was breezy, wonderful weather. As I was dining one morning out in the deck area, I noticed that there's a sliding door that allows you to exit without you having to touch anything. You walk out there, you have your food, and you dine in luxury with the beautiful scenery of the ocean. I noticed a lot of little local birds would be extremely close to where I was sitting and where I was eating because they were opportunistic. You see, as soon as I walk off of where I'm sitting to eat, they would just gather by my food and take my food. I noticed one bird, there was only one bird that was inside the automatic doors, which meant inside the building. You see, people could gather food from the buffet area and then take it outside. When I take it outside, the food that's left over has been picked. I've already eaten whatever I wanted to eat, and whatever's left over are crumbs, where all the majority of the birds are gathering to eat. Whereas this one bird inside has his choice of whatever he wants to eat. So the reason I tell you the story is that in medicine, most of us are like the birds outside. We do what everyone else is doing. Not many of us are willing to take the time to learn something that is new, that is unusual, and implement that practice so that we could advance the care of our patients, advance our practices, and it's truly a win-win situation when you take that chance. Think about Jeff Bezos, think about Steve Jobs, where they just kind of forged their own path. Be aware of something called status quo bias. Common phrases, we've always done it this way. We are going to continue doing it this way. And today's topic on aquablation is a great example. And I urge everyone not to think just about aquablation, but also things such as TURP, whatever procedure that you're used to doing. Don't do it like everyone else. Think of ways to innovate, to do it better so that you can get your pick of whatever you want to eat instead of being stuck outside with the leftovers. Back to you, Vic.
Yeah, thanks. Great story. Now we're going to bring on our guest speaker for the day, who's Dr. Arpeet Shah. He's going to introduce himself. He's got a little story to tell us, and then we'll bring in the show for Aquablation. Arpeet, go ahead.
Hey, Vic. Thanks for having me. It's really a pleasure to be part of this show and talk about aquablation. And I think Dr. Lin says it exactly correctly. You know, the future of medicine is going to rely on innovation, especially as our nation's population continues to grow in age. And specifically in the field of urology, we've always been leaders in terms of implementing new technology and innovation. And a lot of it is based on need because there are just so few urologists and so many patients that we have to remain innovative and utilize new technologies to really serve our patients correctly. My story is a little bit lighter. Vic, you asked me to share a story just a few minutes ago, so I was thinking about it. And one of the most rewarding places where I've got to use my talents as a urologist was actually at Lollapalooza as a resident. And so I wanted to share that story as a second year budding urology resident. I was at Lollapalooza. I was in my 20s with all of my friends, and we were listening to some great music. And I was in the middle of the crowd, packed crowd, you know, thousands of people in the audience. And they had a large central section right in the middle of the audience where there were people in wheelchairs or disabilities who could go on a platform and kind of enjoy the show from a higher view. And I looked back and I noticed that there was one man there who was much younger than the rest, you know, maybe about 15 or 18 years old. And he had somebody with him, and she had a catheter in her hand. And so I was, I was just unique to see a catheter in somebody's hand in the middle of Lollapalooza. So I went to my friend and I was like, oh, I bet that patient has a spinal cord injury and is a neurogenic bladder, and he's going to catheterize himself. And so we continued to enjoy the show. And about 10 or 15 minutes later, I looked back and I saw that same person in the wheelchair turning bright red. You could see him diaphoretic and sweating. And you could see his caretaker or his friend or whoever was with him with the catheter really trying to struggle. And she could see the catheter. You could see the stress in her face. And I said to my friend, I was like, I think he's going autonomic. There's a phenomenon called autonomic dysreflexia, which is a very dangerous situation that can occur when bladders are extremely full in spinal cord patients of certain levels of spinal cord injury. I said, we got to go help them. And so we went up to the platform, and originally security would not allow us in. And at that point, there was a lot of commotion happening in that whole section where they allowed us in, and we were able to successfully put in the catheter, and he immediately felt better before even the paramedics got there. So it was just an interesting scenario that happens. You never know where your skills as a urology practitioner, whether it's nurse or physician or MA or wherever you fit in, where you can help people, because we'll go through the slides about BPH and all that, but urology issues, as we all know, are very common, and a lot of people don't like to talk about them. But if you keep your eyes open, and you can find yourself the ability to really help people. A lighter note on that is after we got the catheter in, they did upgrade us to VIP tickets, so we got to backstage for the rest of the day. So that was definitely an experience that I'll never forget.
Yeah, that's a great story. All right, we're going to bring up your other computer here.
All right. So let me get to that.
Switch. There we go. Good.
All right. Well, it's like I said, it really is a pleasure to be talking about aquablation. This is one of the newer therapies on the market for BPH. And when I present this topic to you, I want you to know that these are kind of my personal opinions about this. Certainly, there is with any new technology, we're still trying to find where the technology fits perfectly into the demographic of patients that we see. And so a lot of it is my opinion. I've been doing aquablation since about 2020, and we were lucky. We committed to purchasing the device right before COVID really hit, and all the budgets were frozen at all the hospitals. And it has been a really great piece of technology to use especially for particularly difficult patients for BPH. And we'll talk about what I mean by that. So, just to give you a kind of a global view, we all know this, but it's important to keep this in mind. So BPH is the significant men's health disease. It's the number one reason why men visit the urologist in the United States. You have about a 50% chance of having BPH by the time you hit 50, and that incidence and prevalence only goes up over time. 99% of men with BPH say symptoms impact their quality of life. And it's estimated that approximately 40 million men in the United States currently have BPH, and that number will continue to rise as the population ages. And that's kind of the last point, is that number will probably double in the next 10 years. So this is, as we all talk about, there's, BPH is going to be a bigger and more common issue that urologists have to face. And a lot of the treatment of BPH is procedural or surgical, and we need to have more innovative techniques to not only improve our outcomes, but allow us to do it in a shorter period of time so we can serve more patients. So defining the symptoms of BPH, I always like to think about this. The one is the ability to hold urine. So that's your storage symptom. So urgency, frequency, nocturia, and incontinence, the ability to, hold your urine. And then we think about emptying your bladder as the second set. So how's the flow, straining? Does it take a while to get started? Hesitancy, weak stream. Does the urine start and stop during the stream? So intermittency, or are you unable to empty your bladder completely? So that would be retention. And this obviously results to quality of life. There's disrupted sleep. It can limit activities, or people are planning their activities around where the bathroom is. And the treatment of BPH, impacts sexual function. So whether it's erectile or ejaculatory function, those are kind of the main things we look at. The surgical market, so the procedural market, is underserved and expected to grow. If you see enough patients with BPH, you know that the medications work for many, but they also do not work for many. And we need to be evaluating these patients in real time. And I always give the comparison to seeing a cardiologist. If you saw your cardiologist, they wouldn't just ask you how you're feeling, how's your heart feeling, and, oh, it's feeling great, you're good to go, I'm going to refill your blood pressure medications, and I'll see you in a year. That's often how urologists manage BPH patients. We ask urinary symptoms, most of the time using the questionnaires, and if the patient is satisfied with their treatment, then we say, great, I'm going to refill your medications and let you go. But I think we are doing many times a disservice to our patients if we're just relying on their symptom score and their opinion on their symptoms. And so just like seeing a cardiologist, they wouldn't just ask you how your heart is, we'll see you in a year. They're going to do some objective testing. And so I'm a big proponent towards objective testing. So the cardiologist might do an EKG and echo, they'll measure the blood pressure. Well, we should be doing the same for patients with BPH, especially if we're managing them. So that can be with Uroflow, Urocuff, or other objective testing. PVR is a great objective test. And then obviously using the questionnaires. But we're really doing a disservice if we're just, refilling medications and assuming that everything is okay. These patients are coming into our office. They are entrusting us with their care. So we have diagnostic testing that can objectively quantify how well they're doing. And we should utilize that testing to make sure that they do not need more treatment for their BPH with procedures or surgeries. And so, these are the numbers. 4.3 million patients choose to do nothing. 6.7 million are managed with medications, of which 1.1 million, the medications really aren't working and they're delaying their surgery despite medication failure. And we're having about 430 surgeries or procedures a year. And this is really where the opportunity lies and where we're going to see a growth in the BPH and surgical market. Because patients are becoming more aware of all the options that they have for BPH. So one of the things is that, the treatment for BPH is there's a great variety, and a lot of it depends on the size and shape of the prostate, as well as the health of the bladder. So we all know prostates come in all sizes, 30 to 40, 40 to 80. I kind of like to break it down in these four categories: small prostates, which are 30 to 40, medium prostates, 40 to 80, large prostates, 80 to 150 cc's, and extra large, 150 and above. And we know that not always does the size of the prostate correlate with the symptoms. And so historically, the procedures that have worked really well for these different sizes, for the small and medium, have been TURP or green light photovaporization of prostate. This is where also we'll talk about non-resective procedures, but these are where the resective procedures come in. And then for the large, we had enucleation such as HOLEP, or a simple prostatectomy, which is often done robotically. I do it robotically. And The constraints are that you're going to have variable complications rates. The time can be intensive. There can be a learning curve, especially with HOLEP. There's plenty of papers that report that the learning curve for HOLEP is hundreds of cases, and that's just quite frankly too much if you're already practicing as a urologist. And then there are size and shape limitations. The nice thing about the resective procedures are you're going to have symptom relief, but the downside is you're probably compromising a little bit more sexual function, continence, and ejaculatory function. That being said, if you poll men, 83% will say that they don't want to sacrifice sexual function for symptom relief, and so that's where the non-resective procedures have come in. And what I describe as non-resective is Resume and Urolift. And the nice thing about those procedures are they prioritize sexual function and continence preservation, but symptom relief can be compromised. I think this is more common, personally, my opinion, in Urolift, and that's what the data will suggest. But the constraints is you might not have as much symptom relief, or it might not be as long-term, and thus you may require retreatment, and there are size and shape limitations. There's kind of an unmet clinical need to eliminate the trade-off between safety and efficacy and the predictability to treat all prostate sizes and shapes. And I think this is where aquablation comes in. If you look at the data, it's approved for prostates, anywhere from the medium to extra large range. I typically, personally, will use it for kind of the 60 to 70 gram prostate all the way to the 150 gram prostate. But really, I do all of the BPH procedures, and I offer all of the ones that I think would benefit the patient based on size and shape of prostate and health of the bladder. But aquablation is really filling this gap of patients who might be too big for a TURP or a green light, but too small for an enucleation or simple prostatectomy, where this is where aquablation really fits in. So how does aquablation work? So it essentially uses high pressure water to resect the prostate. Think of it as almost like a water saw, but it's done extremely precisely using robotic technology. And so what do we mean by robotic technology? So first of all, there's real-time image guidance during the procedure. So you're going to have cystoscopic real-time imaging, as well as transrectal ultrasound real-time imaging, to give you kind of the multidimensional view of the treatment area while you're resecting the prostate. This allows, personalized treatment planning. We use a software during this procedure where we map out exactly the contour that we want left behind of the prostatic fossa and what areas we want resected. And we can change that treatment plan based on the patient's importance towards sexual function, ejaculatory function, and symptom relief. So those are things we can kind of adapt the procedure to. Once you kind of set all the parameters, you just kind of press a button and the robot takes over and uses a water jet along your treatment plan that you made to resect the tissue. And the nice thing about this is it's heat-free at initial resection. So using the water jet, it is heat-free, and it precisely removes the prostate tissue and minimizes the thermal damage to surrounding tissue, which is what can happen with some of the other procedures that are thermal based, and that can impact erectile function. You still do use some heat during the hemostasis portion of this procedure, but the initial aqua beam and aquablation does not use heat. When we are treating the patient, we want to answer a few questions, and we use this during the real-time planning. We're going to look whether there's a median lobe, so you can see that on the number 1 of all of the images. We're going to identify the bladder neck and preserve the bladder neck. We're going to resect the lateral lobes, which are 3. We're going to identify the viramontanum and preserve it. So we put the cystoscope right at the level of the verumontanum, so the resection occurs in front of it or proximal to the verumontanum. And we can see this both on ultrasound and cystoscopically. And we're also going to obviously preserve the external sphincter to make sure these patients remain continent. And this is kind of, you see these 1, 2, 3, 4, 5 listed in the yellow box. That's where you are marking and you are setting a treatment, and you're setting the contour that you want the resection plane to be. And the nice thing is it's relatively independent of size and shape. You can utilize a wide variety of sizes and shapes. So median lobe, no median lobe, and like I said, all the volume characteristics that we talked about. This is really where we see some nice data. The average time for the aquablation resection portion using the robot is about 5.8 minutes on the water studies, which are the premier studies for aquablation. And there is still some work to do afterwards, but if you look at TERP, that's 27.4 minutes. And really, I'm utilizing this for patients who are in the 80 to 150 gram range, where you might be doing HOLEP, where the resection times are significantly higher than TERP. And so time is valuable. It allows you to complete this procedure with the patient under less anesthesia, and from a urologist standpoint, allows you to treat more patients in a shorter amount of time. Thus, you're not booking up, or your patients aren't waiting extended periods of time to get the treatment that they need. And this is a little video you can see of the live image after aquablation. That tissue that you see, that's kind of, you can see the urine flowing out. You can see the system and the prostatic fossa open. But then a lot of the tissue that you see that isn't moving in the posterior portion of the prostate is actually going to all slough off in the first couple of weeks after the procedure. So it's validated in terms of efficacy, durability, and safety. So there's been multiple trials, including a meta-analysis of 4 clinical studies with over 425 patients. They looked at all volumes between 20 and 150 and up to 1 year of follow-up. They really divided the groups up based on prostate size, so above or below 100 cc's, and then whether there was a median lobe or not. And regardless, there were remarkable improvements amongst all prostate sizes and shapes. And so the average results across all subgroups was an IPSS score improvement of 16 points, a flow rate of 20 milliliters per second, a quality of life improvement of 3.3 points based on AUA symptom score, post-void residual improvement of about 60 cc's. And that, 60 cc's might not seem like a lot, but we know that post-void residual is highly dependent on bladder health. And a lot of times patients are being seen after their bladder has already been compromised. And so 62, if you look compared to other literature and other procedures in literature, is pretty high. The ejaculatory dysfunction rate was 10.8, which was very low compared to other procedures. Erectile dysfunction rate of 0% and incontinence of nearly 0. I do have a short video that I'll try to narrate through, and this is the aquablation, just the whole procedure. It is important to know that this, I think, is an inpatient procedure. I know there are some people who are doing this as an outpatient, but if you really talk to those surgeons, it's for the perfect patient, and so they generally do not do these as outpatients. So the first thing you'll see is a transrectal ultrasound will be put into the rectum, and then we'll place the Aqua beam cystoscope. We'll maneuver that into the bladder and kind of fill up the bladder. At that point, there's a robotic arm that is connected to the table that docks the cystoscope. And then we're going to really look at our transrectal ultrasound. And what we'll do is we'll look at AP views of the prostate, and we're going to kind of start planning our area of resection. We start at the kind of the widest area of the prostate and plan our resection that way. And then we'll look at a sagittal view, and we'll look, is there a median lobe? That's what the first dot was marked out, then the bladder neck, then the mid prostate, and then the apex or the verumontanum, or the end of our resection. That yellow shaded area is something called where we're going to do the butterfly cut. And you can make this longer and wider if patients want to preserve ejaculatory function, or you can make it narrower and smaller if ejaculatory function is not of concern for the patient. And at that area, they do a special type of cut using the aquablation, which helps preserve ejaculatory function. And here you see the aqua beam kind of working, and it kind of sweeps high pressure water against the prostate, and you see a live cystoscopic view of this as well. Truthfully, that the cystoscopic view is much more obscured for most patients when you're doing this, but that's a very nice video. And there's continuous inflow and outflow of fluid that is monitored robotically, where you know that you're not over distending the bladder or it's under distending it. And so this is automatically tracked by the robot. You see that shaded area. Once again, they're doing the butterfly cut. So it's not doing a full sweep. It's doing kind of a quarter sweep. This allows for still treating the tissue that's obstructing, but preserving enough tissue where we're preserving ejaculatory function. And it does work. For patients with gland sizes this big, I could never really offer them an ejaculatory sparing technique, but now I can with aquablation. So this is nice. That I think is the end of the animation. So once again, you'll look at the cystoscopic, you can see how obstructed it is. Ultrasound, you can see how obstructed the prostate is. And then afterwards, you can see there's a wide open fossa. You can see the verumontanum is preserved. And using the ultrasound, you can see all the hypoechoic area, which is the new prostatic fossa, which has been opened up. It's very important to know that after we complete the aquablation part of the procedure, I do perform a hemostatic portion of the procedure. So one of the criticisms of this procedure early on was the bleeding and the need for blood transfusion. And so most urologists who are performing this procedure now perform a hemostatic step, which is essentially taking a TERP loop and then putting it into the prostatic fossa and really just cauterizing the bladder neck, not the entire fossa that was opened up, but the bladder neck, because that's where it tends to bleed. And so I put all patients with a catheter. They have a 3-way catheter. They're on CBI overnight. And, I make sure to tell the nursing staff that the CBI should be running and they should be comfortable irrigating the catheter if needed. This is a little bit more of a bloodier procedure than, Resume or Greenlight or TERP. But it works very well. I will, if urine is clear in the next morning and they're able to clamp the CBI and the urine's relatively clear, I'll do a void trial the very next day. And patients certainly appreciate that. And then for the first few weeks, like any resective procedure, Greenlight, even Resume, which is non-resective, TERP, you're going to have symptoms always get worse before they get better. And so frequency, urgency, burning, they're going to be passing little flakes of tissue. That is all expected and normal. I give everybody the analogy that if you had a knee replacement surgery today, your knee would feel worse tomorrow. And it just takes time for your body to heal. And it's important that patients know that the first couple weeks things can get worse before they get better. I continue them on their BPH medications if they're on them for the first 6 weeks or so. And then usually I'll tell them no lifting more than 10 pounds for 2 weeks and no strenuous activity for the first month, and then resuming those therapies. I tend to, I will not do this procedure on anticoagulation, so they need to be approved to stop their anticoagulation, but I will restart it, soon after the procedure. So multiple studies have showed that this works. We kind of went over this, but if you wanted to look them up yourself, they're called the water studies. There's the water 1 study, the water 2 study. The water 1 is for glands from 30 to 80 cc's. The water 2 study is from 80 to 150 cc's. And so it kind of divides those up. The water 1 study does have five-year results, which is nice. And there's a current open study that is multi-center that is coming out. How do I pick patients? So I pick patients who failed conventional medical therapy. I offer conventional medical therapy, alpha blockers and 5-alpha reductase inhibitors to all of my patients. And if they failed it or they don't like taking the medication, then certainly this might be an option. I really care about objective parameters, so size and shape of prostate. Typically, I'm doing these for prostates 80 to 150, but I've done them for less. I've done them for bigger sizes. I make sure the patients know that this is going to be a procedure that they're going to stay over the night in the hospital. The really, really great thing is efficiency in the OR. So I used to do HoLEPs, and they would take me anywhere from an hour if it went perfectly to 3 hours if it was a difficult case. And I'll tell you, I've never done an aquablation that's lasted more than an hour. So I feel like I'm resecting the same amount of tissue as you would as a HoLEP with same efficacy, but less time. And a lot of these cases can take just 30 minutes once you're really efficient and you've done a lot. But 30 minutes to an hour is pretty nice. Learning curve is short. I think it's probably 10 cases, and most surgeons will feel very comfortable performing this procedure. And this is really where I think it has a lot of benefit. This is a procedure that normalizes surgeon skill. Okay, we let the robot and the technology do the resection and do a great resection. It doesn't matter if you're a great urologist or just an average urologist. The resection is done by the robot. You just mark the spots and it does it. And so this allows urologists who do not feel comfortable maybe treating these larger glands to start doing them. Almost every urologist in the country, I'm sure, feels very comfortable with the TURP. And so that's all you kind of really need to know to do this procedure, but you're expanding it to gland sizes that you may not have felt comfortable doing a TURP in the past. And that's kind of how it fits into my practice. 80 to 150 gram prostates, patients who failed medical therapy. It's probably about 20% of my BPH surgical volume. And it's really revolutionized how we treat this particular gland size. I will skip that one. And so, we have 2 urologists in our local practice, which is associated urological specialists who are performing this procedure, myself and Dr. Grant Chavin. So if you wanted more information, we have a website that talks about it, and we certainly have a phone number. And I'm excited to kind of talk about this more with Vic and the panelists.
Helps if I turn my mic on. That was really great. Lori, I think there were some questions that came in. Maybe you could.
Sure. Yep. And I have a question too after I post a couple from Susie Swain. She asked what kind of water is used for the procedure.
Yeah, it's sterile water from your sterile, 3-liter bags of water that you often use for CBI, or you'll see commonly in the OR.
Okay. And then also she asked, what's the purpose of the rectal probe during the procedure?
The rectal probe is a transrectal ultrasound. It's very critical to the procedure. It allows us to see the anatomy of the prostate, to do our planning in terms of marking out where the median lobe is, where the bladder neck is, mid portion of the prostate and verumontanum. And it's really great and helpful during the procedure. You can see the area of tissue that is being resected, not only cystoscopically, but the ultrasound shows better imaging. And so you can see and make sure live while the Aqua beam is hitting that it's hitting the depth that you expect. And if you want it to get deeper while it's going, you can press a button and it'll go a little bit deeper. Or if it's going too deep where you think it's going to affect the bladder neck, or it's getting too close to the periphery of the prostate, you can hit a minus button and it changes the resection. So that's the purpose of it.
Great. And then I had a question also. Can you use this procedure after other failed procedures, not just failed medications?
Yeah, absolutely. I should have said that. I've done this procedure many times after prior failed procedures, and it's been all of them. Urolift, Resume, Green Light, TERPs, and it works. It's not technically, you're going to have some problems with insurance coverage if they have a history of prostate cancer, but from a technology standpoint and from a common sense standpoint, that prostate cancer affects the peripheral zones of the prostate, not the central zones, which are being treated by this procedure. So in real life, I bet there's no impact on treatment of patients with prostate cancer.
Thank you. There's also a question from Karen Dix. Is there imaging done ahead of time, or is it all in the OR?
Well, I'm personally a big fan of objective testing before I decide on a procedure. So for me, I do cystoscopies and transrectal ultrasounds for prostate measurement on essentially all of my patients before deciding on a procedure or kind of narrowing down the options of all the procedures we have for our patients. I'll also do generally a urocuff or at least a uroflow to give an idea of bladder function. And, you don't have to do these tests, but I think most physicians and urologists are doing at least one, if not all of them.
Perfect. And then I also have a question from Elizabeth Hernandez. Is the illustration of the prostate sizes a representation of normal sizes in different stature men? What is the average size of a healthy prostate of a healthy is an average size man?
So that's a tricky question to answer. So prostates can come in all shapes and sizes. Stature does not really impact prostate size. And, the going discussion, in terms of average prostate size, it has a lot to do with age. We know as a man ages, the prostate gets bigger. So if you ask what's the average prostate size for an 80-year-old man, it's going to be very different than a 40-year-old man. But, kind of the going gestalt of average prostate sizes for the patients we're seeing, which typically are over the age of 50, is a prostate size between 30 and 40 cc's.
Thank you.
I've heard a lot about the bleeding being a big concern. Have you gotten in a situation where you go in there and it's just hard to see what you're doing to stop the bleeding, or?
Yeah. So, bleeding was a big concern to a point where, if you look at the original water study, the transfusion rate was 5%, which is quite honestly is astronomical for BPH procedures. And when I was first introduced to this technology, I said, well, 5%, I'm not doing it. I'm just not doing it. And now with the added step of bringing in essentially a resectoscope and a TERP loop and cauterizing, that has gone down, if you look at new studies, to comparable rates of TERP and green light, less than 1%. And yes, I have been in situations where, you can go in and it's very bloody, but you do a couple of these cases, especially if you have one challenging one, you understand how to get the bleeding under control rather quickly.
Mhm.
And so, everybody asks, how long are you taking to resect and to cauterize and for the hemostatic step, which is not described. If you look at all the aquablation literature, they say, oh, it's 5 minutes, a 5-minute case. Yeah, that 5 minutes is the aquablation, right? That's the easiest 5 minutes. Then, the machine's off and you got to go in there and kind of clean up and cauterize everything. And I'll say typically that takes me at this point about 10 minutes. Okay. But at the beginning, my first few cases, it would take, half an hour to 45 minutes. And I have not gotten into a point where I think the bleeding is so bad where I felt like I needed to open up the patient. I have not had any takebacks after this procedure due to bleeding. And so we just did a review. We've done over 100 cases, and between me and my partner, we had one take back for bleeding. It was not my case, but the rates are very low with the cautery step.
Great. Do you put anybody on something like a 5-alpha reductase ahead of time to try to shrink blood vessels as a way of controlling bleeding?
Yeah, I tend to, but we know that 5-alpha reductase inhibitors have significant side effects that some patients want to avoid. So I'll always offer it to patients, but it's not a requirement. There's some, anecdotal stories that say that if you start them on a 5-alpha reductase inhibitor, yes, it shrinks down the size, it reduces the vasculature, but it can make the tissue more dense, which can make resection more difficult. I don't think there's any studies really comparing that and really telling you whether that's true or not. But I'll offer it to everybody. And it's not a really make or break thing whether they're on it.
I would assume that most people are already on it, correct?
Yeah, I think so. But, patients are more aware of their side effects. And so we're seeing, I'm seeing, it's not like when it was in training where, a majority of patients were on it before they were getting some sort of BPH procedure. I'd say actually a majority of patients are not on 5-alpha reductase inhibitors going into a procedure. And it's just because the potential sexual side effects are concerning to physicians and patients.
I have another question from Susie Swain. How long do patients have to wear a catheter after the procedure?
So if they're, I have been conservative in terms of management with the catheter after this procedure because it's a new procedure, and I want to make sure that my patients, we do things in the safest way. But I think after doing over 100 of these procedures, we're understanding that the catheter probably doesn't have to stay in as long as we used to think. So for most patients, I'm doing a void trial the day after the procedure, as long as, the CBI can be stopped and the urine is relatively clear. And so anywhere, we try to do it a day, but if it's a couple days, then we'll do it a couple days in the office later. If they're going in with retention, I typically will wait 3 to 5 days.
Okay, and then from Karen Dix, how does the aquablation compare to Resume with respect to improvement of symptoms?
Yeah, I think, when you compare aquablation to Resume, it's kind of comparing apples to oranges because you're looking at a completely different prostate size. And so symptom improvement is also going to be variant between the two. So, Resume showed, if you look at their 5-year study that was published in the Journal of Urology in 2021, it showed an average AUA symptom score improvement of about 50% after the procedure. And this is pretty similar. And the 5-year efficacy is fairly similar. Resume had a 5-year surgical retreatment rate at about 4% in that study. And the Water 1 study shows a similar retreatment rate. So fairly comparable in terms of outcome, but where Aquablation comes in, it's probably not the same people you're going to do a resume on. It's kind of a different niche of prostate size and shape.
I think what she was thinking too was, like with resume, you tell patients the best result's going to be like probably 2-3 months later, because the prostate has to reabsorb that tissue. There's no reabsorption process. This is actually removing tissue.
Yeah, so they'll have faster symptom improvement. I'll agree with that. Typically, in about 2 or 3 weeks, they're feeling much better after aquablation.
Yeah, well, it's good to have lots of options. So the speaker on HOLEP had mentioned that she had done some patients that had kind of a borderline bladder, decompensated bladder, hypotonic, and had, by getting enough tissue out, they were able to void. Have you tackled any of these on? I would guess Aquablation would do probably the same job.
Yeah, I mean, Aquablation does the same job, and you can say a great TERP would do the same job. When we see this even with Resume and UroLift, that we see patients who have borderline function bladders, potentially, nearly a neurogenic bladder, but we resect enough prostate, or the prostatic fossa opens up, where we decrease the resistance of the prostate towards the outflow of urine, where using Valsalva or whatever bladder function that they have left, they're able to at least empty their bladder. How long that will last, that's highly variable. But yeah, we see it with all the procedures out there. That's a possibility.
Well, that's great.
Great.
Do we have any other questions up from the audience?
No.
I have some comments, if you don't mind.
Sure.
Go right ahead.
I appreciate Dr. Shah's honest discussion regarding aquablation, meaning that it's limited to larger size glands, hemostasis, or the need to go in there right after the aquablation robotic procedure to perform that hemostatic procedure. People don't talk about that. And I appreciate that you honestly and openly discuss that, because that can take a little bit of time. Also, the fact that you said this is truly an inpatient procedure and not really an outpatient procedure, that's also underplayed for a lot of patients, for a lot of discussions. And I really appreciated that frankness and openness. I do things differently. And again, like you said, this is the way you do it. This is your experience. The way I do TURPs, for instance, I do, if patients opt in for it, consistently put the patients on 5-alpha reductase inhibitors. I do not wait until medication failure before I offer a TURP procedure. And also, I stopped the TURP. I stopped the BPH medications the day of the TURP, because I've made the prostate wide open. Why do I need to leave the patients on medical therapy? So much of what we do that's the way we were trained, dogma. TURPs also, once you get really good at doing them, all of my patients are now done as outpatients, meaning they go home the same day. And also often they don't go home with the catheter. Yeah, tubeless. I do these as tubeless button TURPs.
Yeah.
In addition, yeah, go ahead.
I would agree. I think most of my TURPs are going home the same day. I'm a little bit conservative with in terms of catheter. I won't do tubeless that day. That's really remarkable, and I think that's what we need. We need innovative urologists who are pushing things to help our patients and get them catheter free sooner.
And just like the situation with the 4-minute mile, Roger Bannister back, I think in the 1950s. Before him, no one ran a sub 4-minute mile until he started doing it. He broke that 4-minute mile barrier, and then everyone else started doing it. Same thing with TURPs. A lot of people don't realize that you can perform an ejaculation preserving TURP. Now, I'm now doing this as an outpatient procedure, sometimes without a catheter, and able to preserve ejaculation function after TURP. I have numerous videos on Sunrise Urology's YouTube channel. If you look on the playlist of TURP, BPH procedures, numerous patients tell me that their sexual function actually improved after TURP, even though they may or may not experience retrograde ejaculation, meaning no semen coming out after TURP. Their sexual functions improved after TURP. So a lot of things that we don't quite understand why treating BPH improves sexual function, but it certainly does.
Yeah, and I'd agree with that. And some of the stuff you're doing in terms of, ejaculatory sparing TURPs, and you can do that with green light. You can even do it with Resume. We need to continue to be innovative, and some of that just comes from experience and trying it out and being innovative as a surgeon. But this is one of the, I say Aquablation, only about 20% of my BPH surgeries, but this is one of the really remarkable things about Aquablation is that it normalizes surgeon skill, right? So, the machine kind of does it for you. So whether you've ever done an ejaculatory sparing TURP or procedure or not, it will tell you how to do it, and it'll do it. And that's kind of a nice thing where we're opening up the ability for urologists everywhere who do not feel comfortable doing ejaculatory sparing TURPs or same, outpatient TURPs, the ability to kind of treat these patients and to kind of offer the innovations that you talk about and that, some urologists are doing in terms of sparing ejaculatory function.
One of the other limitations of aquablation is that it does not treat the anterior prostate. As you've seen many times after performing cystoscopy, prostates are not all the same. Sometimes that obstruction comes from a drooping anterior lobe of the prostate. Sometimes it can be intravesical. That portion of the prostate, you still have to go in there and resect if you want to treat that after an aquablation.
Yeah, and actually, one of my failures after aquablation was due to anterior tissue, and so sometimes you don't even notice that anterior tissue until you've completed the procedure. They're healed, and they're still having symptoms, and weeks down the line, you look in and you see this kind of draping tissue. And you're absolutely right that's another limitation towards aquablation therapy.
And I completely agree with the need for objective testing, uroflow, PVR, post-void residual, urocuff to assess bladder function, cystoscopy, transrectal ultrasound. Those are basic. I also, I think of myself as a savior or a crusader against defunctionalized bladder. And often a lot of these guys who are older, they ignore their problems. And by the time they see us, the bladder is already partially decompensated. By waiting and leaving them on medication, the bladder tends to deteriorate even more. Often when I see these guys and I do the objective testing, I see obstruction. I don't even put them on medication. I offer treatment, definitive, expirative treatment before I even say medication, because I know they're obstructed right now. And medication, you put them on medication, even combination pharmacologic therapy, alpha blocker and 5-ARI, you do a cystoscopy on day one, and then you do a cystoscopy 6 months later, the prostate is going to look the same. The obstruction is still there.
Yeah.
So I often don't even offer medication. I do offer it, but I say, you know what, this is most likely not going to cure you. If you want to cure, if you want to preserve bladder function here on out, consider having something done.
And I completely agree. I think most often, if you talk nationally for urologists, they're probably surgically treating prostates too late. Okay. How many times have we seen a patient in the ER with retention and he's like, I just saw my urologist. He said I was doing great on medical therapy. And those are the patients we're failing. And we're failing because we're not objectively testing their bladder and their prostate early and regularly. Okay. So if I have a patient who says, I feel like I'm doing great on Flomax, okay, I will still recommend a urocuff to make sure that they are objectively. And if they're not, I'll tell them, I know you're feeling great, but your bladder's not saying that you're feeling great. And that's certainly not what the objective testing is showing.
Yeah, and Euro cuff certainly can display that very, very well. Be a defender of the destrucer, everyone.
Absolutely.
Well, this has been a great discussion. We're getting to the end of our hour, so I am going to call the meeting to an end. Great talk, Dr. Shah. I really appreciated you coming on and discussing that. There's a lot of options for treating BPH, and we need to look at all those choices. And I think that when you can get a doctor to give you real honest information, that's the most important part of all of this. So I'm just going to move on to just plug next week's 1 year anniversary show. Don't miss it, folks. You do need to be live. So save that date because we're going to be having our raffle. And if you're not live, you can't be part of the raffle. We got a couple of Euronurse shirts that we're giving away. Soon is offering a 1 year membership. And now Chicago Metro soon is going to offer a pass to their spring conference. Whether you come to it live or want to attend virtual, you'll be able to get the credits. So that's another option for you. It's also a little plug for something that's going to happen. We're going to open it next week, and that's a new part to Euronurse, something new coming. I think you're going to like it. I would like to thank everybody, thank all of our speakers here. It's been a great show, and we'll see everybody next week.
Thank you, everyone.
Thank you.
Bye.